So the NEET-PG exam was held on 5th March and the results are already out. Hello, I'm Dr. Shivika Sethi, the faculty for microbiology at Marrow. And I'm going to be giving a quick analysis of the questions that were asked on infectious diseases or the organisms. So there were about 25 questions on infectious diseases. So that would constitute about 1/8 of the paper. And the questions that were asked were from routinely asked topics, the important ones. There were no bouncers in the exams. There were questions from the topics that are commonly asked in most of the exams. So let's just brush through them. So as I already mentioned, there were about 25 questions. I'm going to be discussing about 13 of them. The rest of the questions will be discussed either by the medicine faculty or the pediatrics faculty or dermatology or OBG faculty, right? So let's just brush through the topics that I'm going to be discussing. So from the topic of parasitology, we had questions from trematodes, trichomonas, plasmodium, leishmania, and filariasis. From viruses, we had the commonly asked herpes viruses in the form of HSV, CMV. Then we had arboviruses, dengue, and of course, we had a question from rotavirus. From bacteriology, we had question from meningitis that is caused by Haemophilus, leptospirosis, and gonorrhea. And from mycology, we had a question on pneumocystis pneumonia. So I would say these topics are very commonly asked, especially herpes viruses, spirochetes, and arboviruses, also gonorrhea, right? In fact, sexually transmitted infections. These are routinely asked topics in our exams and always considered important. Okay, so let's get going. Which of the following statement is true about Trichomonas vaginalis? It is not a sexually transmitted infection. Wet saline mount of vaginal secretions show cysts. Twitching motility is seen on wet saline mount. It cannot be cultured. So only correct statement about Trichomonas vaginalis is the fact that it has twitching motility. Okay. So yes, of course, it is the most common sexually transmitted parasitic infection. So this is an incorrect statement. Wet saline mount of vaginal secretion would show trophozoites. Why? Because Trichomonas vaginalis is a unique pathogenic protozoa which has no cyst stage. That's why, since there is only trophozoite, it is an obligate human parasite. Okay, it cannot survive outside the human host. It cannot be cultured. Well, this might have confused many of the students. We generally don't talk about culturing the protozoan organisms. We generally talk about cultivating bacteria. But yes, most protozoan organisms can very well be cultured on several media. We've studied about them in our classes on marrow. Okay, yes, it can be very well cultured. So twitching motility is the only correct statement. Generally, we relate twitching motility to a bacterium that is Eikenella. And sometimes we also talk about twitching motility of the Neisseria species because of their type 4 pili and Pseudomonas. But yes, twitching motility is also of Trichomonas vaginalis, which I have talked about in my marrow videos. Okay. So trichomoniasis, the most common parasitic sexually transmitted infection, has no cyst stage. Hence, it becomes an obligate human parasite. And this is its typical morphology. It's a pear-shaped structure, 4 flagella anteriorly, and the 5th flagellum is folded along an undulating membrane. There is a single nucleus. Okay. And this is what has a twitching motility or a wobbling motility or a rotatory motility or a jerky motility. So lots of synonyms: jerky, rotatory, or wobbling motility. Okay, that's the motility of Trichomonas vaginalis. Right. So some important points I'm going to be discussing now about Trichomonas. Now, just would like to tell you that we've been asked about 13 questions in microbiology, and I am going to be discussing the important point about these microorganisms, keeping in mind the previous year questions. So last 5 years questions related to that particular organism, I'm going to be revising with you rapidly, right? It's not going to be a very long session, so just bear with me and go through these important things. So trichomoniasis typically described as the patient presenting with a frothy, offensive, foul-smelling vaginal discharge. And on colposcopy, what we see is strawberry cervix, also called as colpitis macularis. Colpitis macularis. So that's because of the micro ulcerations produced on the cervical mucosa. Trichomonas can be cultured on several media. The most commonly used medium is called as the CPLM medium, or it's also called as the Trussell and Johnson's medium. CPLM or Trussell and Johnson's medium. It can also be grown on the Diamond's medium, which is also used for growing Entamoeba histolytica. Okay. The gold standard method for diagnosis remains the nucleic acid amplification test like PCR. Okay. And the treatment is giving metronidazole, or so that's to be given for 7 days, or we can give tinidazole. That's a single dose of 2 grams, right? So that's the strawberry cervix appearance or the colpitis macularis appearance. Let's move on to the next question. A boy came with fever and chills. Rapid test for specific antigen HRP2 is positive. Which of the following is the likely cause for the symptoms? Plasmodium falciparum, vivax, ovale, and malariae. I hope these were the options. The answer is definitely Plasmodium falciparum, right? We've studied about them. The malaria rapid diagnostic tests, these are immunochromatographic tests, which are also called as lateral flow assays. Okay, so these are strip-based tests which detect Plasmodium antigens in the patient's blood. The pan-malarial antigen, which is common to all species of Plasmodium that is tested for, is either LDH or it is aldolase. So these antigens are circulating in the patient's blood. And the Plasmodium falciparum specific antigen is what we were asked about, HRP2 antigen. Okay. So these are very rapid tests, right? Can just get the result within a few minutes, but the sensitivity is relatively lower in comparison to the other methods that are used for the diagnosis. So they can detect about 50 to 100 parasites per microliter of blood. Okay. So this is the picture or the image of the malaria rapid diagnostic test. So there is a control band that has to come positive for saying that the test is valid. And if there is only one band, that is control band, which is coming positive, that means the patient does not have malaria. If all the 3 bands, that is control band, the pan-malarial antigen, and Plasmodium falciparum antigen band come positive, that means it is either pure Plasmodium falciparum infection or it's a mixed infection along with Plasmodium falciparum. And if there is only 2 bands, that is control and pan-malarial antigen, that means it is a non-falciparum malaria. Failure of the appearance of the control band means it's an invalid test, right? Now, remember, regarding malaria diagnosis, the gold standard method for diagnosis remains microscopy. It's a very cheap method, and its advantage is that it can identify the species also. It can also quantify the parasitemia. Sensitivity of microscopy is around, it can detect 5 to 10 parasites per microliter. So with a thick smear, the sensitivity is 5 to 10 parasites. With a thin smear, that's a sensitivity is around 200 parasites per microliter. This is whatever I'm talking about is in relation to per microliter. And after preparing the peripheral blood smear, the stains that we use are generally the Romanowski stones, which are like Fields, or we can use Giemsa, or we can use Leishman, or we can use the Wright stain. But according to the National Malaria Eradication Program, what is used in India is the Jaswant Singh Bhattacharya stain. Okay. So that's regarding the stain, right? We move on to another question which was asked recently. There was a peripheral blood smear of a child who had come with seizures and high-grade fever, and the peripheral blood picture was shown like this. There were multiple rings in the RBCs. We were asked, what is the treatment of this patient? So obviously this child had cerebral malaria, which is due to Plasmodium falciparum. So I'm just quickly highlighting what is distinct about Plasmodium falciparum. peripheral blood smear. As you can see, these are the multiple early trophozoite. Multiple rings are seen, right? And also you can see the multiple chromatin dot. The ring has two chromatin dots. These are also called as the earphone sign. Okay, so multiple chromatin dots, these are the banana shaped gametocytes, and I hope you can appreciate one a ring form which has gone to the side and attached to the RBC membrane. These are called as the applique forms or the acole forms. Okay, so that's characteristic. And also remember that in Plasmodium falciparum and Plasmodium malariae, the RBCs are not enlarged. They are absolutely the same as the size as the non-parasitized RBCs, right? So this was the peripheral blood picture which was asked recently in AIMS exam. And how do we treat such patients of cerebral malaria? That was what was the question. So what treatment we can give is either quinine with doxycycline, or we can give quinidine IV. So this is of course IV with atovaquone plus proguanil, or we can give artemether IM with atovaquone and proguanil, or we can give artesunate IV with atovaquone and proguanil. Okay, so this was what was the question was talking about. That was what was the options amongst the in the question that was asked, right? Other methods for diagnosis apart from microscopy and malaria rapid diagnostic tests, one is the quantitative Buffy coat method, also called as the microhematocrit tube method. The advantage is it can detect as many as 2 parasites per microliter of blood. So better sensitivity than microscopy, definitely. But the issue is that this is an expensive method for diagnosis, and it always requires a fluorescent microscope. And also we can do the nucleic acid amplification tests like PCR if they are available in that laboratory. These would obviously be the most sensitive methods for diagnosis. Okay. Right? But please remember the gold standard method for diagnosis of malaria is microscopy. And yes, we can definitely culture. Since we just talked about cultivation of Trichomonas, let's just talk about cultivation of Plasmodium. Yes, it can be grown on RPMI medium. Roswell Park Memorial Institute medium. That's the medium used for growing Plasmodium. Okay, another question that was asked recently in AIMS exam was, which are those genetic factors which contribute to resistance to severe malaria? So many hemoglobinopathies like hemoglobin S, hemoglobin F, then G6PD deficiency, and thalassemias. All of them confer resistance to severe malaria. Severe malaria is generally because of Plasmodium falciparum, and all these hemoglobinopathies somehow they reduce the development of the Plasmodium falciparum in the RBCs and hence protect from severe malaria. And also remember that Duffy antigen, Duffy blood group antigen, if it is deficient on the surface of the RBCs, what is it conferring? It confers resistance to Plasmodium vivax, because the receptor for Plasmodium vivax on RBCs is the Duffy blood group antigen. If it's absent, obviously it is going to, the RBCs are resistant to Plasmodium vivax infection. Also remember that 2 species of Plasmodium are associated with relapses because of the hypnozoites which are hiding inside the hepatocytes, and when they reactivate, they lead to relapses, which are the 2 species, Plasmodium ovale and Plasmodium vivax. So what does relapse mean? Over and over again. So over and over again. From that, remember that it is ovale and vivax which are associated with relapses. Let's move on to our next question. Clonorchis sinensis increases the risk of which of the following? That's very, very easy question. Of course, it is cholangiocarcinoma, because Clonorchis sinensis is a liver fluke. It localizes in the biliary tract. So obviously, a chronic infection would be associated with an infection, cholangiocarcinoma. That's where it is localizing. Okay. Right. Carcinoma of the. So remember, there are three trematodes. Trematodes, what are they also called as? Flukes. These are carcinogenic. Which are the carcinogenic flukes? One is, of course, what we have been asked, oriental liver fluke, that is Clonorchis sinensis. The other one is Opisthorchis. There are two species of Opisthorchis, but the one which is viverrini, that is associated with cholangiocarcinoma. So both these are associated with cholangiocarcinoma, and carcinoma bladder is because of another fluke, that is schistosoma hematobium. Where does it localize? It localizes in the vesical plexus. Okay. So squamous cell carcinoma of the bladder, that is associated with schistosoma hematobium. A quick review of the trematodes, because we were recently asked over a big question on flukes. So when we think of the trematodes or the flukes, these are all leaf-like. Okay, and which are the organisms which immediately strike our mind? One are the blood flukes, that is Schistosoma mansoni, Japonicum, and Hematobium. Then we come to the liver flukes, which localize in the biliary radicals. These are Fasciola hepatica, Fasciola gigantica, Clonorchis sinensis, and Opisthorchis species like Opisthorchis viverrini and Opisthorchis Felinius. Felinius is not associated with cholangiocarcinoma. Then we have GI flukes like Fasciolopsis busci is the most important, though there are at least 2 to 3 more like Gastrodiscoides, Metagonymous, and Heterophyes. Okay, and finally we have the oriental lung fluke, that is Paragonymous westermanni. Okay, so these are the important trematodes that you should always be remembering about. And schistosomes are the jumping jokers of the trematodes. They want to be different on all accounts. So all trematodes are leaf-like, but schistosomes have a split body. The male worms have they have a gynecophoric canal like this, which is meant to hold the female during fertilization, right? So they have a split body. They don't look like these liver flukes. Okay, then for all of them, the definitive host is human, and they have the first intermediate host in the form of snails, and most of them have a second intermediate host in the form of either freshwater fish or freshwater plants. Now, you're supposed to know the names of these freshwater plants because that's what was asked in the question. So what are these freshwater plants? They are called as watercress, or they're called as water chestnut, or they're called as water caltrops. Okay, these are the freshwater plants which can harbor the metacercariae of the trematodes. Okay, and all of them are hermaphrodites except the schistosomes, which have separate sexes. Separate sexes meaning they are also called as dioecious. So all of them are monoecious, but schistosomes are the ones which are dioecious. And all trematodes are acquired by ingestion. Obviously, ingestion of either freshwater fish or freshwater plants which are harboring the metacercariae, except the schistosomes. These are acquired by skin penetration by cercariae, and usually there is a history of swimming. Okay, so freshwater swimming in a lake or something like that. Okay, so this is common to all trematodes, and we must have realized that schistosomes are the jumping jokers. They have a split body. They only have one intermediate host in their life cycle, that is the snails. They just manage with the S that is associated with the schistosomes. They say we don't require the freshwater fish or the freshwater plants. All of them have separate sexes. They are acquired by skin penetration. We're talking about the schistosome. The rest of them are all hermaphrodites. They are acquired by ingestion. Now, we're talking about the liver flukes. right? So we have Fasciola hepatica, gigantica, clonorchis, and opisthochis. We've learned the definitive host is always humans. The first intermediate host is the snails. Snails are also called as mollusks. Okay. Second intermediate host for Fasciola hepatica and gigantica is freshwater plants, the names I told you just now. But for Clonorchis sinensis and Opisthochis species, it is freshwater fish. Okay. Mode of infection, ingestion of metacercariae in unwashed water plants or poorly cooked fish. And what is their pathogenicity? Most of the time they are asymptomatic, but they can lead to cholangitis, they can lead to cholelithiasis, or they can lead to cholecystitis. And these two, Clonorchis sinensis and Opisthochis viverrini, are associated with cholangiocarcinoma. Okay, we've talked about that earlier. Let's move on to our next question. A lady from West Rajasthan presented with an ulcer surrounded by erythema on the leg. Microscopy of the biopsy from the edge of the ulcer showed organisms with dark staining nuclei and kinetoplast. Which of the following is the likely cause? Babesia, trypanosoma, Leishmania tropica, and histoplasma. Now, this has been repeatedly being asked in the last couple of years, and anything related to kinetoplast, what should immediately strike your mind is the class Kinetoplastidae of the flagellate protozoa. Which is this class? That is, which contains Leishmania and it contains trypanosoma. So that's our answer. Leishmania tropica. Why not trypanosoma? Trypanosoma causes Chagas disease and it causes, what does it cause? Sleeping sickness. Neither of these diseases are reported from a resident of West Rajasthan. They are not reported indigenously from our country. Either they are reported from Africa or they are reported from the South America. Okay. So this, yes, we do know trypanosoma and Leishmania have kinetoplast, but our answer here is Leishmania tropica. What is this causing? It is causing cutaneous leishmaniasis. Cutaneous leishmaniasis, which is also called as the oriental sore, also called as the Baghdad boil or the Delhi boil. So it is very well reported from India, though more often reported from the Middle Eastern countries and Upper Africa. Okay, so Babesia and histoplasma can be easily eliminated because they do not have kinetoplast. Please remember that amongst the flagellate protozoa belonging to the phylum Sarcomastigophora, there is a class called as Kinetoplastidae because they have a special type of extra chromosomal DNA. They have a special type of extra chromosomal DNA, which is called as the kinetoplast. And this is further made up of blepharoplast and the parabasal body. Blepharoplast and the parabasal body. And kinetoplast is only present in either Leishmania or trypanosoma. Okay, so Leishmania, yes, we know it causes visceral leishmaniasis or Kala-Azar. It causes cutaneous leishmaniasis or oriental sore. Both these diseases are reported from India. Another disease that it causes is mucocutaneous leishmaniasis or Espandia, but that is only reported from South American countries. So obviously our diagnosis in this case becomes cutaneous leishmaniasis, and our answer was Leishmania tropica. That's the causative agent in our country. Okay, so that's what we saw on microscopy. That is the double dot sign inside the macrophages. So what is this structure of Leishmania tropica that is seen inside the macrophages? It is the amastigote stage. Amastigote stage of Leishmania inside the macrophages. So the double dot sign basically is, these are the tiny, that's the amastigote, the nucleus, and the kinetoplast at the base of the remnant of the flagellum. This is the double dot sign that you can appreciate. This one, this one, this one. Okay. Right. So please remember that leishmania, there are two stages in its life cycle. One is the infective form that is inoculated by the bite of the sandfly, that is the promastigote. This also has the kinetoplast and it has the flagellum externally attached, extending out externally. And this is our amastigote stage that is inside the macrophages. And that's the typical cutaneous leishmaniasis, which is caused by Leishmania tropica. It can also be caused by Leishmania major, but this is in our country. Leishmania mexicana and Leishmania ethiopica. Okay. These are the common species causing cutaneous leishmaniasis. Right. Now, this is a very controversial question. I would say it's an ambiguous question because I have got variable, feedbacks on this question. Now, this is what I could understand. I mean, this is what I got from the students. Some students, a patient from Bihar presented to the OPD with a history of high-grade fever and severe weight loss in the last few weeks. Now, the Bihar thing, the first thing that strikes us in Bihar is Kala Azar, right? So, but further investigations on this patient revealed circulating filarial antigen test is positive. So what is this telling us? This patient is having filariasis because this is a very sensitive test. It's an immunochromatographic strip-based test, which is highly sensitive, meaning 93 to 99% sensitive for filariasis and 100% specific for filariasis. Okay, so this patient is suffering with filariasis. What is the next best step that can decide the appropriate management of this patient? Now, what is confusing here is what is this severe weight loss attributed to? Now let's read the options. DEC provocation test, microfilarial detection in blood smear, bone marrow biopsy, ultrasound scrotum. Now, as I told you, this circulating filarial antigen coming positive is telling us it's pretty specific for filariasis. Why do we need to do all the other tests? Straight away, what we can either do is just, prepare a peripheral blood smear, or we can do the DEC provocation. I'll just talk about these tests. But I fail to understand why these thing was mentioned. The patient has high-grade fever can be seen because that's a acute filarial fever. But why is this patient having a severe weight loss? Why is this history of this geographical history associated? So what I think was that the question was something like this. A patient from Bihar presented to the OPD with history of high-grade fever and severe weight loss in the last few weeks. On examination, the patient is pale and has splenomegaly. Now, this looks a possible question. Further investigations revealed circulating filarial antigen test is positive. So this would tell us this patient has Kala Azar, and this would tell us that this patient has filariasis. What is the next best step that can decide the appropriate management of this patient? What would you think? You would like to manage the Kala Azar also, and you would like to manage the filariasis also. So for Kala Azar, what would you like to do amongst these options? You already know that this diagnosis is done. What would you like to do? You would like to do a bone marrow biopsy. And what would you like to show? The A mastigotes of Leishmania donovani. That would tell you, yes, this patient is also having Kala Azar, so we should be treating for Kala Azar plus filariasis. Right, so give amphotericin B and give diethylcarbamazine for treatment. So this was most likely the question, and I would say bone marrow biopsy should be done because no other option is talking about how we can otherwise diagnose this Kala Azar. So that's the best possible option for diagnosis of Kala Azar, and that would tell us this patient should be managed for both of these conditions. Right, but I'm not sure about what was the history. If it was this, then I would go and mark bone marrow biopsy. Now let's see the other option. Suppose the question did not talk about Kala Azar at all. A patient presented to the OPD with history of recurrent attacks of high-grade fever in the last few weeks. Investigations revealed circulating filarial antigen test is positive. What is the next best step that can decide the appropriate management of this patient? Now, here we just have acute filarial fevers plus the CFA, circulating filarial antigen test is positive. Now, what would you like to do? You would like to prepare a peripheral blood smear to confirm the diagnosis of filariasis, right? That would tell, yes, we need to treat this patient. But microfilarial antigen, when do the microfilaria appear in the patient's blood? In the night time. They have a nocturnal periodicity. So what would you like to do? You would like to correct the peripheral blood smear, the blood sample between 10 p.m. and 2 a.m. Can you do that? Can you ask the patient to come and give his blood sample in the night? No, not possible. Who's going to wake up in the night, change your clothes, come to the hospital care? The technician comes, the patient comes. Not possible. So what would you like to do? You would like to do the DEC provocation test. That would just give a small dose, 2 milligram per kg body weight of diethylcarbamazine. All the microfilaria will come out in the peripheral blood running around. So that would be the possible answer. So I would, in this situation, I would do the DEC provocation test to make the microfilaria appear in the peripheral blood and to collect a blood sample and then prepare a peripheral blood smear of this patient to demonstrate the microfilaria, right? Yes, even ultrasound scrotum can be done in case the microfilaria are not visible in the peripheral blood. You can look out for, do a Doppler ultrasound and look out for the adult worms, which would show the filarial dance sign that I'll just show you the video of soon, right? So this is a slightly vague question, but in this question, I would mark DEC provocation test to confirm the diagnosis of filariasis, okay? So whatever was the question, let me just quickly go through the diagnosis of filariasis. So we need to demonstrate the microfilaria which appear in the night time. So peripheral blood smear microscopy should be done. So do the DEC provocation test or the hetrazan provocation test and collect a peripheral blood sample to prepare a peripheral blood smear. But before that, I would like to do the concentration methods. What are these? Either the Knott's concentration method or do the membrane filtration technique. These would concentrate the microfilaria. So that would increase the sensitivity of the microscopy and then do a microscopy, right? So that's the Knott's concentration method. Just take a little bit, 1 ml of the patient's blood, mix it to 10 ml of formalin and centrifuge this blood mixture for 2 minutes and then decant the supernatant. Just collect the sediment and on the slide and stain it with Giemsa to demonstrate the microfilaria, or do the membrane filtration test, that is the polycarbonate membranes which have a specific size of the pores that would trap the microfilaria, and then you can place the filters on the microscope slide to demonstrate the microfilaria, right? Another question that have been asked in the last 2 years is they gave a history of fevers and they showed that on peripheral blood smear microscopy of we are seeing such and such microfilaria. So if there are no nuclei in the tail tip, that means it is Wuchereria bancrofti. If there are 2 nuclei in the tail tip, the answer is Brugia malayi, right? So you can just pause this video if you want to study more about the differences between the microfilaria of Wuchereria and Brugia malayi with each other. But just remember the biggest difference is absence of nuclei in the tail tip of Wuchereria bancrofti and 2 nuclei in the tail tip of Brugia malayi. An easy way to remember that has been suggested to me by a very intelligent student is Wuchereria bancrofti. So just remember this, it has a bank full of nuclei. It has a bank full of nuclei, so it does not require its tail to keep the nuclei in it. And Brugia malayi, how do we go to Malaysia? Either mostly as a couple of friends. So think of 2 people going to Malaysia. So there are 2 nuclei in the tail tip, right? Moving on to other methods for diagnosis of filariasis, we can detect filarial antigens in the patient blood. That's what we were talked about in the question, either by ELISA or by lateral flow assays or immunochromatographic tests. These are 93 to 99% sensitive for filariasis and almost 100% specific for filariasis. Okay. And the advantage of detecting antigens is they are positive at all times of the day. You don't need to collect a night sample for putting up the antigen tests. Another method for diagnosis is detecting filarial antibody in the patient's blood, but this is useful only in non-endemic areas like United States, etc. It's mentioned on the CDC site on for as a method for diagnosis, but it has a limited role in diagnosis in endemic countries like ours. We might get exposed to the antigens of Brugia or Wuchereria during a blood meal by a mosquito which is carrying the L3 larva of either of these. We might not get the infection, but we might still get exposed to the antigens and form antibodies against them, right? So they have limited role in diagnosis in our country. Yes, we can collect a blood sample during the night time to make the microfilaria appear in the peripheral blood, or do the DEC provocation test and then put up the QBC, that is the quantitative Buffy coat or the microhematocrit tube method, to detect the microfilaria by concentration, by centrifugation. Okay. But as I said earlier, also for Plasmodium, these are expensive tests. They require a fluorescent microscope. Most sensitive, of course, would be the nucleic acid amplification tests or nucleic acid probes carried out on a blood sample. Also, a method for diagnosis is doing Doppler ultrasound to detect the filarial dance sign. You can carry it out on the scrotum or on the breast or inguinal lymph node to detect the adult worms which are present in the lymphatics or the lymph nodes, right? So you can see that filarial dance sign. Let's move on to a question. I talked about this question to our PSM faculty, Dr. Mohit. He said, ma'am, some student has told me that the question was asking us what is the next best step according to the National Vector-Borne Disease Control Program. He says, according to this program, the answer should be microfilarial detection in the peripheral blood smear. Ask the healthcare worker to go and collect the blood sample during the night time from the patient's house itself. Okay. So he said this is according to, you don't know the DEC provocation according to the vector-borne disease control program. Okay. So that does with our ambiguous question. Let's move on to our next one. A 1-year-old child is brought to the emergency with multiple seizures, fever, headache, and neck rigidity. CSF analysis showed low glucose, high protein, and many polymorphs. So what is it telling us? This is most likely a bacterial meningitis. Okay, that's the characteristics. Culture grew pleomorphic gram-negative bacilli. Now, this is our biggest hint. Pleomorphic gram-negative bacilli causing meningitis in a 1-year-old child. What is the organism you're going to think of? Of course, this is Haemophilus influenzae. When we think of meningitis in children, especially 1-year-old children, either we think of Streptococcus pneumoniae or we think of Haemophilus influenzae, right? So obviously this child has not been vaccinated with the HIV vaccine. Okay. So Streptococcus pneumoniae would be gram-positive, cocci in pairs, whereas Haemophilus influenzae would definitely be pleomorphic gram-negative bacilli. Right? So what is the true about the organism? Is it sensitive to bacitracin? Of course not. This is a character of Streptococcus pyogenes, which is also called as the group A beta hemolytic Streptococcus. Okay. Alpha hemolytic on cheap blood agar. Yes, this is positive for Streptococcus pneumoniae. But in that case, what would be written? That these are gram-positive cocci, which are diplococci and lancet-shaped. Satellitism around Staph aureus colonies. That's our answer. Haemophilus influenzae shows satellitism. Non-lactose fermenting colonies on McConkey. This is definitely not an answer. I don't know of any agent which is non-lactose fermenting and causing meningitis in a 1-year-old child. These would be very, very rare causes. Something like salmonella would be non-lactose fermenting. And yes, it can definitely cause meningitis, but that would be very, very rare. And it would not be written as pleomorphic, right? So our answer here would be option C. A quick review of Haemophilus influenzae without going into the details, just the important points. Hemophilus, it's blood loving because it requires X factor and V factor. What is X factor? It is hemin or any other porphyrin containing compound, and V factor is NAD or NADP. Now, when we grow Haemophilus, when we try to grow Haemophilus on a blood agar, it gets the X factor freely, but the V factor is trapped inside the RBCs. So you need to lyse the RBCs, and then it would get both X and V factor and grow luxuriantly on that medium. So how do you lyse the RBCs? Either you prepare chocolate agar, right? It would get X and V, or you use a Staph aureus streak. So that's our blood agar plate. And we have streaked across Staph aureus, and we have also streaked our colonies of Haemophilus influenzae. Okay, and you can see since Staph aureus is beta hemolytic on blood agar, it would lyse the RBCs, and all the Haemophilus would be just becoming satellites of Staph aureus because they are getting X factor, otherwise also, plus they're getting V factor just close to the Staph aureus streak. And what is this phenomenon called as? Satellitism. Right? So chocolate agar, blood agar with Staph aureus streak. What are the other lysed blood containing media we know of which are used for growing Haemophilus? That's Fild's agar and Leventhal's medium. Right? These are all containing lysed RBCs. Another question that has been asked recently regarding Haemophilus influenzae: what are you going to treat this patient of meningitis with? You're going to use third generation cephalosporins. Why use third generation cephalosporins? Because Haemophilus influenzae has many plasmids which encode beta lactamase, which can hydrolyze the penicillins and first and second generation cephalosporins. But third generation cephalosporins, it is quite sensitive to. So that's what is the drug of choice for this case of meningitis. And what is the HIV vaccine? Had the mother given this vaccine to the baby, he would not have developed this meningitis. This is Haemophilus influenzae serotype B vaccine. What is this constituted of? It is containing polyribosyl ribitol phosphate, PRP. What is this? It is the capsular antigen of Haemophilus influenzae serotype B. Capsular antigen, and this is generally conjugated to a carrier protein. You know, polysaccharide vaccines on their own are not immunogenic, especially in children. So they need to be conjugated with a carrier protein. This could be a carrier protein like a outer membrane protein of Neisseria meningitidis, or it could be diphtheria toxoid or tetanus toxoid, right? So HIB is a conjugate vaccine. And what is it constitute by? Most important constituent is PRP. Okay. Now, this image came 2 years back in the AIMS exam. We were shown this CSF picture of a patient with meningitis, and we were asked what are the characters of this organism. So what do you see out here? You can see these purple colored, and what are they? Diplococci. And some of them, you can appreciate them as being lanceolate shaped. So what are you thinking of? Immediately, we're going to think of Streptococcus pneumoniae. And what are the characters of Streptococcus pneumoniae you can think of? Just quickly, rewind. All streptococci would be catalase negative, What about Streptococcus pneumoniae? It is alpha hemolytic on blood agar. And which are the two important biochemical reactions we always remember for Streptococcus pneumoniae? The fact that it is optogen sensitive, then it is bile soluble. And one more important thing that was mentioned in the question that time was that it ferments inulin. Inulin fermentation test is positive. Okay. So with these two we generally remember optogen sensitive, bile soluble, but what was mentioned in that is it is fermenting inulin. Please remember that we have another streptococcus which is alpha hemolytic on blood agar. Can you think of which one? The viridans group of streptococci. So sometimes we can get confused which one it is, viridans group or streptococcus pneumoniae. So in that case, we need to know these differentiating points, and I've talked about them in my lectures, that viridans group are negative for inulin fermentation, they are optogen resistant, they are bile insoluble. Okay. Right. Now, this would be the picture in case it is meningococcus. Even this has been recently asked. CSF image where you can see the gram-negative diplococci. Okay. And remember what are the characters of meningococcus? Of course, the meningitis has a very characteristic picture. It is associated with petechiae, purpuras, and ecchymosis. Okay. And meningococcus would be catalase and oxidase positive. And which are the sugars that it utilizes? It utilizes glucose and it also utilizes maltose. Both these sugars are utilized. And of course, it is capsulated organism, capsulated gram-negative Diplococcus. Okay, we move on to questions on viruses. Diagnosis of rotaviral infection is most commonly done by which of the following? Rotaviruses, of course, we've studied in our routine classes, that usually diagnosed by detecting antigens in the patient's stool, either by ELISA or by immunochromatographic tests or by latex agglutination tests. Any of these can be used for detecting the rotavirus antigens in the patient's stool sample. Okay. Of course, the antigens would not be detectable in the patient's blood. They would be only detectable in the stool. Antibody detection in the serum, not useful at all, because patient can have pre-existing antibodies, maybe from an earlier exposure to rotavirus or an earlier incidence of rotavirus infection. So even this would not be useful. What about light microscopy of a stool specimen? Is this possible? Can you see viruses under the light microscope? Of course not. You can only see them under the electron microscope, right? So our answer here is option A. So that's the electron microscopic picture of a stool sample of a child suffering with rotavirus infection. You can see some empty shells and you can see some complete virions. What appearance do we describe it as? What appearance? Wheel-shaped forms. Wheel-shaped. Rotaviruses have very special characters. First of all, we always know when we think of diarrhea in young children and infants, what are we going to think of immediately? Rotaviruses. And which group or which family of viruses do they belong to? Reoviruses. Reoviruses. And reoviruses have a very characteristic capsid. They have a triple layered capsid, and that gives them a wheel-shaped morphology under the electron microscope. They are non-enveloped, and the special genome of rotaviruses, it is a double-stranded. It's a double-stranded RNA genome, and there are 11 segments in the genome. 11 segments. Okay. And what does a segmented genome confer the virus the ability to undergo? Genetic reassortments. Just like influenza viruses have segmented genome and new strains keep on arising of influenza viruses, so also rotaviruses show genetic reassortments. Now, this genome encodes 6 structural proteins, which are called as VP1, VP2, 3, 4, VP6, and 7. And it encodes 6 non-structural proteins, NSP1, 2, 3, and so on and so forth. Now, there are 7 serogroups of rotaviruses on the basis of 2 structural proteins, VP2 and VP6. And what we need to remember is A, B, and C. These are the only 3 serogroups which are associated with human infections, human disease. The rest of them, including A, B, and C, cause diarrheas in animals. Right. Now, another thing that has been asked recently about rotaviruses is that it has a non-structural protein 4, which is an enterotoxin. In fact, rotaviruses were the first viruses which were discovered to have or encode an enterotoxin. What is that? NSP4. Okay, this was a NEET question about 5 years back. It was asked, which of the following is an enterotoxin of rotavirus? NSP1, 2, 3, and so forth. Okay, so our answer is 4. And another question that was asked recently is regarding RotaShield. That was the first reassortant vaccine which was introduced in 1998, and it was associated with the complication of intussusception. So this was the question that was asked. And that is why it was discontinued at that time. And only 8 years later, new reassortant vaccines were introduced from 2006 onwards, and newer vaccines against rotaviruses are now being produced even in India. These include some like Rotarix, Rotatec, etc., Rotavac. These are all oral vaccines which are live attenuated, and they are reassortant vaccines. Okay. Moving on to our next question. A sewage worker came with complaints of fever. Now, the first thing that strikes us in this question is sewage worker. And what should immediately come into your mind? Of course, this is leptospirosis. Comes with complaints of fever, abdominal pain, and blood in urine. On examination, the patient has jaundice, hepatomegaly, and conjunctival injection. I don't know if it was conjunctival injection or it was conjunctival suffusion. Basically, it means redness of the eyes without a purulent discharge, without a discharge. What is the investigation of choice? So what's our diagnosis here? Leptospirosis. Sewage workers wade through water which is contaminated with urine of so many animals, and if they have any abrasion on their skin, they would get infected with the leptospires, which is present in the urine of the carrier animals. Okay, so which of the following is the investigation? Is it the Weil-Felix test? That's the one to trick you out, because leptospirosis is also called as Weil's disease. But the Weil-Felix reaction or test is done for many rickettsial infections like epidemic typhus, endemic typhus, Rocky Mountain spotted fever, etc. But definitely not for leptospirosis. The answer is microscopic agglutination test, which is the gold standard test. It's the gold standard serological test. Gold standard serological test for diagnosis of leptospirosis. Okay, though it is not easily available. Why? Because we are handling it, requires the maintenance of several serotypes and serogroups of leptospires. So it's only done in research laboratories. So patient's serum is collected. It contains antibodies, and we look for agglutination of the leptospires in the presence of the antibodies. But this is the confirmatory test, the gold standard serological test for leptospirosis. Where is Vidal test done? It is done, of course, in case of suspected typhoid and paratyphoid. Paul Bunnell test is used for the diagnosis of infectious mononucleosis. Okay. So yes, our answer is option A. microscopic agglutination tests. This we have studied in our regular lectures on marrow. Now, quick review of leptospirosis. It is a very, very common zoonotic infection in worldwide, and it's present as the leptospires are present as normal bacteria which are present in the collecting tubules of the carrier animals, especially rodents, but so many domestic animals like dogs, cows, and horses, etc. And how do we get infection? Exposure of either mucous membranes or exposure of abraded skin to urine contaminated water. So obviously people who are, especially it is seen in people who wade through water or handle infected animals like veterinarians, sewer workers, this was what was mentioned, generally mentioned, milkers, rice field farmers, butchers, and hunters. Or sometimes there might be an outbreak. There's a group of people got exposed. They went for some water games and got exposed to the contaminated water. And it's often reported whenever there are floods, there are outbreaks of leptospirosis when we wade through that water. So leptospirosis, as I said, a very common zoonotic infection. It's a biphasic illness. So after an incubation period of about 2 days to 20 days, patient initially comes with an acute stage or also stage called as septicemic stage or leptospiremic stage, which lasts about 1 week. And the characteristic manifestations in this is fever with chills, myalgias, nausea and vomiting, conjunctival suffusion, a characteristic calf muscle tenderness, and a pretibial rash. These are very characteristic findings, though they are not seen in all patients, right? And yes, the patient also may have lymphadenopathy and hepatosplenomegaly. And in the second stage, the patient goes into the immune phase, which lasts for 4 to 30 days. And here the patient has these symptoms along with jaundice, renal failure, hemorrhages. That's why leptospirosis is also called as icterohemorrhagic fever, also called as hepatorenal syndrome. Hepatorenal syndrome or Weil's disease, or the disease associated with the 3 R's. What are the 3 R's? Rats, rice field, and rainfall. Rarely we might have patients coming with aseptic meningitis, cardiac arrhythmias, and uveitis. Okay. Right. So that's about the typical manifestations which were mentioned in this question were conjunctival suffusion, jaundice, renal failure in the form of hematuria. These all were mentioned. And of course, the typical occupation. Another question that is commonly asked is, what is the treatment of leptospirosis? If it's a mild disease, we just give oral drugs in the form of doxy or ampi or amoxicillin. And if it is a moderate or a severe disease, we treat parenterally either with penicillin or with ceftriaxone, or we give ampicillin. In our last AIMS exam, that was last year, not this year, we had a patient of leptospirosis, was treated with penicillin, and in a few hours, the patient developed fever, chills, hypotension, nausea, vomiting. What is this happening? This reaction is called as the Jaris-Herxheimer reaction. It's because of the release of endotoxin or other membrane components of leptospires when they are lysing on treatment with penicillin. And this leads to the release of cytokines. Which are these cytokines? Interleukin 6, interleukin 8, and TNF alpha. These induce the appearance of all those symptoms in the patient, but these are short lasting. Okay. So that's a typical morphology of leptospires. It's a closely wound spiral with either one end hooked or both the ends hooked, too slender to be seen by the light microscope. So how do we see it? Under the dark ground microscope. And what is special about all spirochetes? They have what are called as endoflagellae. So this was asked and is an image-based question about 6 years back. This was the morphology shown, and we were asked to identify what is this bacterium. The answer to that was leptospires. So endoflagellae are present in the periplasmic space. They're also called as axial filaments. A very, very commonly asked question. A patient with history of unprotected sex comes with dysuria, urethral discharge. Gram stain is shown. What is the treatment to be given to this patient? What are you seeing on gram staining? Something gram negative cocci inside the macrophages. Obviously, what are we going to think of? We are going to think of Neisseria gonorrhoeae. So this patient is having gonorrhea. Okay, so how do we treat a patient of gonorrhea? With a 500 milligram intramuscular single dose of ceftriaxone. And usually patients of gonorrhea also have a concurrent infection with chlamydia trachomatis D to K. So if you cannot confirm whether the patient is having a simultaneous infection with chlamydia trachomatis, combine it with doxycycline, give it for 7 days. If you cannot do a PCR for genital chlamydiasis, right? This was an image-based question. 1 year back, purulent discharge, that is so characteristic of gonorrhea. Purulent urethral discharge. Okay. A few important points about Neisseria gonorrhoeae. How do you differentiate Neisseria gonorrhoeae from Neisseria meningitidis? Of course, we talk about morphology differentiating the two, but on gram staining, hardly we can differentiate that morphology. So Neisseria meningitidis is typically described as half moon shaped or lens shaped, whereas Neisseria gonorrhoeae is described as bean shaped or kidney shaped. Neisseria meningitidis is capsulated. This is non-capsulated. And the most important biochemical by which we can differentiate them is that Neisseria meningitidis uses or utilizes both glucose as well as maltose. But Neisseria gonorrhoeae, it's Neisseria G, so it only utilizes glucose. So Neisseria M utilizes also maltose. Neisseria G only utilizes glucose. Neisseria gonorrhoeae is notorious for showing antigenic variations in several of its components like pili, lipooligosaccharides, as well as outer membrane proteins, which help it to evade the immune response of the patient. Neisseria gonorrhoeae. In females, the infection can start as a cervicitis. It can go on to salpingitis, pelvic inflammatory disease. And an important complication is perihepatitis, that is Fitzhugh-Curtis syndrome, which is also seen with genital chlamydiasis. And gonococcemia or septicemia of Neisseria gonorrhoeae can manifest in several sites. So sometimes you can be given a clinical history, right? He has multiple sexual partners, has some history of purulent urethral discharge, and presents with any of these symptoms. What is this? Patient of gonorrhea says, date me. So what is this? Dermatitis. So skin papules or pustules, arthritis, septic arthritis, especially of the knee, ankle, or the wrist joint. This is tenosynovitis. And rarely the patient may have meningitis or may have endocarditis. Okay, so keep this in mind that these are the symptoms of or manifestations of disseminated gonococcal infection. What predisposes to a disseminated gonococcal infection? Can you name a couple of risk factors? One is menstruation, and the other is terminal complement component deficiency. Okay. Next question. A patient hailing from Delhi with a history of 3 days of high-grade fever develops extensive petechial rashes and arthralgias. Hemoglobin is 9%, WBCs are reduced, so the patient has leukopenia, has thrombocytopenia, bleeding time is prolonged, but clotting time is normal. What is the most likely diagnosis? I don't know if some other things were mentioned in this. Raised hematocrit was mentioned, hypoalbuminemia or hypoproteinemia was mentioned or not. But typically, what would you think of? Looking at this, this patient is having dengue hemorrhagic fever. What is the WHO definition of dengue hemorrhagic fever? Patient should have a history of fever. Patient should have thrombocytopenia. Should have some hemorrhagic manifestations and evidence of plasma leakage due to increased vascular permeability in the form of some ascites or pleural effusion or hypoalbuminemia, or the patient may have hypoproteinemia, etc. Right? Or raised hematocrit might be mentioned. Right? So answer here is dengue. Okay. I don't think malaria would be associated with thrombocytopenia. Scrub typhus would, we had different manifestations. Eschar would be seen, right? And I don't think it is associated with platelets reduced, etc., or bleeding, etc. Typhoid, rose spots are seen, not petechial rashes. Right, so we have arthralgia. Dengue, we know, has that typical breakbone fever. So our diagnosis definitely becomes dengue hemorrhagic fever. So dengue virus causes the most common arboviral disease in the world, and there are 4 serotypes, then 1 to 4, which do not have no cross protective immunity. So infection with one serotype does not provide protective immunity against the other serotypes. Okay, it's what family does it belong to? Flaviviruses, which are single-stranded RNA viruses which are enveloped. Okay, now dengue virus. One other question that has been asked recently is what are the risk factors for dengue hemorrhagic fever? Dengue hemorrhagic fever risk factors. Remember, females, whites, age less than 12 years, good nutrition. So malnourishment is considered as protective. Then Southeast Asian Den 2 strain infection or Den 1 infection followed by Den 2 infection. These are the risk factors for dengue hemorrhagic fever. Whites, females, age less than 12 years, good nutrition, these two infections. Okay, that does with our, just a couple of points regarding diagnosis. What is the most common modality for diagnosis? It is detecting IgM antibodies. Generally, what is most commonly used is ELISA. Also, we can use immunochromatographic tests, latex agglutination, or indirect fluorescent antibody tests. This becomes positive by 5 to 7 days of disease. 5 to 7 days. Okay. Now, this is serology. Then you can also detect NSP1 antigen. This becomes positive. Please note, antibodies are appearing by the end of almost the end of the first week. This becomes positive on the first day to about 7th day of disease. This antigen can be detected in the patient's blood. We can also do a blood PCR. This is also first day to 5th day. Yeah. Okay. One more point to remember is what is the culture medium? Which is the culture medium most commonly used for growing arboviruses? It is mosquito cell lines. Mosquito cell lines. And the name of this cell line is C6/36. Okay, those are the modalities for diagnosis. Most commonly, IgM ELISA MAC ELISA is used. And please remember, yes, dengue virus can be cultured. A patient was brought to the emergency with high-grade fever, headache, neck rigidity, and altered sensorium. Altered sensorium. What does this tell us? This is encephalitis. The patient had seizures in the hospital and was provisionally diagnosed with HSV encephalitis. Okay, this is herpes encephalitis. Diagnosis can be confirmed by, of course, this question has been repeatedly asked every 3 to 4 years. What is the answer to this? Do a PCR on the CSF for viral DNA. That's our confirmatory test. Yes, if you can get a brain biopsy, please, you can do. That is considered as the gold standard, but almost equally sensitive is doing a PCR on the CSF. IgM antibodies in the CSF do appear, but they appear after 1 week of the illness. So you're not going to wait for detecting the antibodies. You would rather do immediately a CSF PCR for viral DNA. Zank smear of the CSF. How silly. What a silly option. What do you do a Zank smear on? On the skin lesions. You just take a scraping from the base of the vesicle and stain it with methylene blue. And then you can see those multinucleated giant cells. So this is not possible on a CSF specimen. CSF culture on chick embryo cell lines. Yes, herpes viruses can very well be cultured on chick embryo. They would form pox on the chorioallantoic membrane, but or even on chick embryo cell lines, but these would take at least a week and sometimes even up to 4 weeks. So, right, so our answer is PCR for viral DNA. This is asked every 3 to 4 years. So, herpes encephalitis, the most common cause of sporadic encephalitis in the world. Okay, what is the most common cause of epidemic encephalitis in our country? Can you think of? It is Japanese encephalitis. This is mainly in Southeast Asian countries, which are endemic for Japanese encephalitis. But when we talk about sporadic encephalitis, this is definitely herpes encephalitis. And more than 95% of herpes encephalitis is due to HSV1. Okay. And it could be either due to a primary infection, or it could be because of the reactivation in the neurons of the sensory ganglia. And what is the site of the brain which is most often affected? It is the temporal lobe. And so the patient might have come with symptoms of memory loss, or may have speech problems, or may be aggressive, or may be having hallucinations. Right? And there is a bimodal age distribution, 5 to 30 years and more than 50 years. That's the typical age affected with herpes encephalitis. And of course, the treatment is acyclovir. And this is to be given for 2 to 3 weeks. And we've learned already about the diagnosis, CSF PCR. Okay, a child presents with history with fever, malaise, and rashes. Urine examination showed cells that have nuclei with owl eye appearance. What is the likely infection? Such an easy question. When we talk about a nucleus which has owl eye inclusions, what is this? This is definitely CMV. CMV, or human herpes virus 5, or salivary gland virus, produces owl eye inclusion bodies. It's a unique virus which produces both intranuclear. So the owl eye ones are the intranuclear, and it also forms intracytoplasmic inclusion bodies. Okay, both sides. Can you think of another virus which forms both intranuclear and intracytoplasmic inclusion bodies? It's measles virus. These are the only two viruses which form both inclusion bodies in both the sites, nuclei as well as cytoplasm. Okay, so our answer here is cytomegalovirus. Okay, CMV, those are the owl eye inclusion bodies of CMV. Cytomegalovirus or salivary gland virus, all of us are infected with it. Most of us are already having CMV latent at some site in the body. Could be salivary glands or kidneys, or it could be any tissue of the body, right? And whatever cell it infects becomes big, and it has those inclusion bodies. Now, what are the diseases or manifestations of CMV? Let's just brush through them, and we are almost at the end of our discussion. In healthy individuals, it is usually an asymptomatic infection, but rarely it can present as disease resembling infectious mononucleosis. But here there are no heterophile antibodies against sheep, horse, or ox RBCs. That's why it is also called as heterophile negative infectious mononucleosis. Okay, how would you diagnose it? By detecting IgM anti-CMV antibodies in the patient's blood. Coming to a CMV infection in pregnancy, it's usually a primary infection in pregnant woman, especially in the first 28 weeks of pregnancy. It gets transmitted across the placenta to the fetus, and the fetus unfortunately develops what cytomegalic inclusion disease. In 5 to 10% of infected fetuses, this disease is seen. It's the most common agent transmitted across the placenta. And what are the manifestations of CID? We were asked this question in our exam, which will be discussed by either our pediatrics faculty or OBG faculty. Typical things are mentioned: microcephaly, chorioretinitis, deafness, periventricular calcifications, petechial rashes, jaundice, atypical lymphocytes seen in the blood. Okay, and diagnosis before delivery can be done by doing a PCR on the amniotic fluid, and after birth can be done by detecting IgM anti-CMV antibodies in the baby's blood. It's the most common virus causing opportunistic disease in HIV, and it is here usually a reactivation due to the immunosuppression. Usually disease is seen when the CD4 counts fall below 50, right? And what is this HIV? What is the manifestation? Usually most commonly presents as chorioretinitis, which is called as pizza pie retinopathy, or cottage cheese and sauce appearance. Can also lead to CMV colitis, esophagitis, pancreatitis, pneumonitis, nephritis, and so on. And it's the most common virus causing opportunistic disease in transplant recipients. And here, what does it do? It can manifest as most commonly CMV syndrome, which is just presenting as fever with leukopenia or neutropenia along with thrombocytopenia. Or it can lead to pneumonitis, nephritis, colitis, esophagitis, and so on. Okay. So it's the most common agent of all these. The most common agent causing heterophile negative infectious mononucleosis, and we already registered all these most commons here. Coming to our almost at the end. Yeah, last question. A 45-year-old male presents with complaints of persistent dry cough and weight loss for the last 2 weeks. He had a history of contact with multiple sexual partners. When this is usually mentioned, it indicates some sexually transmitted infection, generally HIV. He was diagnosed as HIV positive 6 months back and is poorly adherent to his medications. So his CD4 count is down to 145. Fungal culture of the sputum was negative. On Gomory's methenamine silver staining, crescent-shaped cysts are seen. What is the responsible organism? Now, whatever this history was, it was HIV with a low CD4 count, with a persistent dry cough and weight loss. When we think of persistent dry cough in a patient of HIV, what are we thinking of? PCP. Okay. And this is further confirmed by the GMS staining. Okay. GMS means we are talking about a fungus. The fungal culture has come negative, but what are we seeing? Crescent-shaped cysts. A fungus forming cysts. Which is this? Of course, it is pneumocystis. Okay, pneumocystis 0 with C. That's our answer. What is the responsible organism, right? So I don't know, I'm not sure whether it was crescent-shaped written, or it was written as hat-shaped forms, or it was written as ping ball appearance. Or sometimes, in the question it is written as rounded structures around the size of RBCs. We know the size of RBCs is around 7 microns. So the cysts of pneumocystis are somewhere around 5 to 8 microns. So this is definitely pneumocystis. So these are the forms, the hat-shaped or the ping pong. You know what are ping pongs? Have you seen those small white plastic balls you play tennis with? right? So if you just press them from one side, they become crescent shape like that. That's called as a ping pong ball appearance, right? And these are the hat shaped forms. So these are the cis. On Gomori's methenamine silver, we can only see the cis of Pneumocystis erovetsi. But if you want to see both the trophozoites and the cis, then of course you have to stain with Giemsa. Giemsa would demonstrate the trophozoites as well as the cis of Pneumocystis. Right. Pneumocystis is a unique fungus. It was earlier classified as a protozoan organism because what we saw in microscopy was trophozoites and cysts, but it is a fungus because when mitochondrial DNA studies were carried out, ribosomal RNA studies were carried out, it had chitin in its cell wall. Just like all fungi, it had beta 1,3-D glucan in its cell wall. It was decided it is better classified as a fungus, not as a protozoan organism. But what is unique about Pneumocystis, apart from the fact that we are seeing the trophozoite and the cyst, is that it lacks ergosterol in its cell membrane. It's the only fungus which lacks ergosterol in its cell membrane. And with this, what are we going to remember? Most of antifungal agents are inhibiting the growth of or the synthesis of ergosterol. So antifungals are ineffective against Pneumocystis. So what do we treat it with? The drug of choice for it is cotrimoxazole. Okay. So remember Pneumocystis. How do we acquire it? By inhalation. And what is the typical pneumonia that it leads to in mostly people who have certain risk factors like HIV, with primary immunodeficiencies, transplant recipients, etc.? What is typically mentioned? Bilateral interstitial pneumonia. Or sometimes what is, instead of writing this, what is written is perihilar infiltrates. So this interstitial pneumonia generally starts from the perihilar region and then spreads to involve the other sides of the lungs. And of course, certain complications can be seen. Yeah, one more point, it's a non-cultivable fungus. Right, before I missed out the symptoms. Persistent dry cough with progressively increasing dyspnea, cyanosis, right? And what sample do you collect? Do you collect the sputum sample? Hardly. It's a persistent dry cough. So what do? You ask the patient to inhale hypertonic saline, and that will induce the production of a watery sputum that is called as an induced sputum. And that has a very good yield to demonstrate the cysts and the trophozoites of Pneumocystis, right? So microscopy, we can use either Giemsa to demonstrate the trophozoites, which are smaller, 1 to 4 microns. The bigger ones, the 5 to 8 microns, are the cysts. And you can do culture. No, it's a non-cultivable fungus. So instead of that, you can do a direct fluorescent antibody testing, which is very sensitive, or even more sensitive would be the nucleic acid amplification tests, right? So we've talked quickly about Pneumocystis, what is it, how do we acquire it, what is the disease it causes, and how do we diagnose it, and we know the treatment. It's definitely not an antifungal, it's a cotrimoxazole. Okay. Now, the other options that were mentioned in the question, they're all acquired by inhalation, histoplasma, coccidioides, or what else was mentioned in the question? uh, Paracoccidioides. These are all acquired by inhalation, but you would not see cysts in them. You would see something else. So what is that something else you're going to see? In case it is coccidioides, in a lung biopsy, you would see spherules filled with endospores. So 30 to 60 micron spherules filled with endospores. This is coccidioides. Okay. In case it is paracoccidioides, what would you see? You would see a yeast which is showing multiple buds. Sometimes you can see just 2 buds. What does this look like? It looks like Mickey Mouse appearance. And if you see multiple buds, what is this appearance called as? Mariner's wheel or captain's wheel or pilot's wheel appearance, right? So yeast with multiple buds would be seen in paracoccidioides, and this would be seen in histoplasma. You would see narrow budding yeast cells, which are around the size of 2 to 4 micron. Of course, here you would see a single bud. So this brings us to the end of our questions. Many other questions on infectious diseases will be taken up by other faculties, right? So at the end, I would just like to tell you all that, in this world, attitude is the little big thing that makes a huge difference. Keep always a positive attitude. Never think that you are below the others. If you have not scored very well, you have not studied from a very good central college, it doesn't matter. You can do whatever, you can do the best to achieve your dreams only by keeping a positive attitude. Bye bye.